So I'm going to talk on only Holmes Adie people because I thought initially I'll talk on both Holmes Adie people and Argyll Robertson people. Then I'll be rushing for the clinical science of both people. Then it will be it will not be very interesting. So I just want to focus very slowly on one particular topic today on Holmes Adie people. Holmes Adie people or Holmes Adie syndrome, because syndrome is a constellation of signs and symptoms. It's just not a people. There are some other additional signs. So it's called as Holmes Adie syndrome. It's a disorder in which there is a parasympathetic denervation of the affected people, resulting in a poor light but better and tonic near constriction. So if you throw a light, there is a poor light contraction, but there is a reasonable good tonic near constriction. The affected people, either unilateral or bilateral, typically initially appears abnormally dilated at rest and has a poor or sluggish pupillary constriction in bright light. So you see both people, one people look little larger and you throw light and it has a very poor response to light, and you do a near constriction, it responds to the near constriction. That's a classical feature of the tonic people, Holmes Adie syndrome, Holmes Adie people. It is usually unilateral, it can be bilateral. Constriction is typically more notable with near reaction and typically remains tonically constricted with slow redilatation with segmental paralysis of the iris sphincter. So that after you finish the near constriction, the near reaction constriction, then you allow the people to settle down. It will take some time to dilate again. And the segmental paralysis of the iris sphincter, you have to pick up by there's a special clinical examination. You have to do a slit lamp examination to pick up the segmental paralysis of iris sphincter. It's not clinically outside by eye noticeable. Patients may also present with decreased deep tendon reflexes in the full Holmes Adie syndrome. So people can have tonic people, mostly unilateral. They can have additional absent deep tendon reflexes. That constitutes the Holmes Adie syndrome. The Holmes Adie syndrome, tonic people, a near light dissociation and tendon areflexia has been associated with a range of autonomic disturbance that includes. So these patients, the Holmes Adie syndrome people, can have additional autonomic disturbances. Orthostatic hypotension. So they complain of dizziness, check the BP and find whether the BP is dropping down on standing. Impaired cardiovascular reflexes. Segmental and generalized hypohidrosis called as Rose syndrome. So if the patient is tonic people, the areflexia, if they have hypohidrosis or sweating disturbance, segmental or generalized pattern, that is called Ross syndrome. So sweating disturbance, areflexia, and tonic people, the combination is called as Ross syndrome. Carotid gustatory syndrome, they can have gustatory syndrome and they can have chronic diarrhea. So they can have a dysautonomia in addition to the tonic people. So whenever you see a tonic people patient, look for the reflexes and look for the knee dysautonomic features with this patient. This combination is called as Holmes Adie syndrome. Limited histological studies in this condition indicate loss of ganglion cells in the parasympathetic ciliary ganglia, which correlates with the pupillary abnormality. So the pathology is in the ciliary ganglia. There is a damage to the ganglion cells. Degeneration of the dorsal root ganglia or the fasciculus gracilis and cuneatus may explain the absent tendon reflexes. So the pathology is in the ciliary ganglia, which explains the tonic people, and dorsal root ganglia explains the absent tendon reflexes. Autonomic dysfunction has been variously ascribed to lesions of both afferent and efferent sympathetic and parasympathetic neurons. So these patients can have, they have a combination tonic people, and they can have areflexia, they can have dysautonomia, and these combinations called as Holmes Adie syndrome. Although Holmes Adie syndrome is considered to be benign and of unknown etiology, troublesome symptoms may result from autonomic dysfunction. These include hyperhidrosis, heat intolerance, and syncope. So when you see these people with abnormality, they have this dysautonomia. You have to specifically look for what are the clinical symptoms or signs they can have. They can have hyperhidrosis, oversweating, heat intolerance, and they can have sometimes syncope. It is named after William John Adie, the British neurologist of Australian descent, and Sir Gordon Morgan Holmes is an Irish neurologist. So, as a British neurologist and Irish neurologist, the British neurologist of Australian descent. The combination is called, the name is Holmes Adie syndrome or the Holmes Adie people. They both reported the condition in 1931. Adie named it pseudo Argyll Robertson people. So it was initially named differently, but subsequently they named the author's name of Holmes Adie people. In 1881, Hugling Jackson had described mydriasis with pupillary paralysis. In 1906, Marcus first described the tonic people. So there are people talked about this over a period of time before it was consolidated into the Holmes Adie people. In 1914, Olaf had shown that tonic peoples could be caused by factors other than syphilis. So initially, those days, people know that no, it was called as big pox. Syphilis is called as big pox, and everything they say syphilis, and because syphilis is so common those days. So that time that it was mistaken for AR people, but subsequently they know it is totally a different condition. It is a tonic people. The incidence is approximately 4.7 per 100,000 population per year. Young adults are usually between the ages of 25 and 45. Mean age of 32 years are most commonly affected. The female preponderance is 2.6 is to 1. There is a more female preponderance. That is 2.6 female is to 1 male. That is the ratio. Is more common in the female population. It is sporadic. Is commonly reported rare reports of familial association. Unilateral in 80% of cases. So you see this in unilateral in 80% of cases. There can be a familial cases. There can be unusually familial association report in some of the cases. It is sporadic. Holmes Adie syndrome, relatively common neurological disorder of unknown etiology. It is unilateral or bilateral, tonically dilated pupils with light near dissociation and tendon areflexia. Symptoms result from autonomic disturbances affecting vasomotor and pseudomotor function, which I was telling initially. The vasomotor and pseudomotor function, they sweating and all those things, hyperhidrosis all comes under pseudomotor. Vasomotor like syncope, all the blood pressure issues and all those things comes under vasomotor. So they can have vasomotor and pseudomotor function abnormalities. Rarely caused by local disorders involving the orbit that affect the ciliary ganglion. We have to keep in mind, even though we know it is idiopathic and there is no reason, it is a common unknown etiology disorder in neurology, one of the common unknown etiology neurological disorder, that it can be there can be a secondary reason for this tonic people or Holmes Adie people, like infections, syphilis, varicella, human papilloma virus B19, human immunodeficiency virus, and Lyme disease can produce affection of ciliary ganglion, can produce the tonic people. Ischemia, lymphomatoid granulomatosis, migraine, and giant cell arteritis can produce secondary tonic people. Autoimmune disorders like Sjogren's syndrome, polyarteritis nodosa, sarcoidosis, systemic lupus erythematosus can involve ciliary ganglion, can produce a tonic people. Amyloidosis, Guillain-Barré syndrome, walked Koyanagi-Harada disease can produce. Orbital or choroidal tumors, orbital surgery for orbital floor fractures can produce. Neuromuscular conditions such as Lambert-Eaton myasthenic syndrome, there are case reports of ciliary ganglion involvement in these patients because it's a paraneoplastic disorder. Paraneoplastic in association with anti-HU antibodies. May caused by retinal photocoagulation that results in damage to the ciliary nerves within the suprachoroidal space. So if you do a retinal photocoagulation, people come with this kind of tonic people, then we have to keep in mind it can happen in them because of damage, specific ciliary nerve damage due to photocoagulation. An association with familial dysautonomia has been reported. Recently, 2 cases reported due to SARS-CoV-2, the COVID virus, reported due to neurotropism. There is direct involvement of ciliary ganglion by the virus, and there is a delayed immune-mediated mechanism. These are 2 mechanisms of ciliary ganglion involvement in COVID viral infection. 2 cases recently reported producing a tonic people. It has been published. So what is evaluation? How do you evaluate? How do you examine these patients? Hallmark is strong and tonic response to near stimulation with a slow and sustained relaxation due to iris sphincter aberrant regeneration and hypersensitivity to muscarinic receptor agonists like pilocarpine. So you will have a tonic response to near stimulation and a slow and sustained relaxation. So that while throwing a light, the reaction is not good, but near association while they are converging, that you can see that is a contraction of the people. That is a contraction of the people, and it is when it relaxes very slowly. Over time, the tonic people, which is usually larger than the uninvolved fellow eye, tends to become smaller, a condition that is known as the little old Adie people. So keep this point, very important point. And that suppose that usually the tonic people in the initial phase or the beginning phase, it is usually larger than the normal size. And over a period of time, when it becomes a chronic disorder, it tends to become smaller than the uninvolved eye. That is known as the little old Adie people. The little old Adie people can be diagnosed by the poor light reaction and the tonic near response. So the reaction is more or less same. The pupil is smaller, not larger like the initial phase of the tonic pupil. Even it becomes smaller than the uninvolved eye, it behaves like the same tonic pupil. So there is not much reaction to the light. To near contraction, it contracts and it relaxes slowly. Approximately 20% of Adie pupils are bilateral with a 4% incidence of bilateral involvement per year. So you see 20% people can have a bilateral tonic pupil. It is not uncommon, and the incidence become 4% per year. Bilateral involvement incidence increases slowly. So that over a period of time, initially it starts unilaterally, they may become 4% chance of becoming bilateral over a period of time. Anisocoria greater than 1 millimeter and the presence of sector palsy on slit lamp examination helps to differentiate Adie syndrome from mydriasis due to general neuropathy. Suppose the patient has a third nerve palsy or some other cause. Then you see the pupil is larger in tonic people most of the time in the initial phase. And if you are not very sure, then if you do a slit lamp examination after all this near contraction and light not reacting to the light, then you can see a sector iris on particular sector. There is a palsy in slit lamp exam. That gives a clue it is a tonic pupil. Pharmacological testing, low concentration of pilocarpine, that is 1/8 to 1/10%, not the routine pilocarpine dose. It may be useful to demonstrate cholinergic denervation supersensitivity. 80% prevalent in the tonic people. So that is the drops you put into the eye to find out whether it is a tonic people. After the administration of the diluted pilocarpine, a more miotic response will be seen in the affected eye compared with the normal fellow eye. The low concentrations are usually ineffective in the normal people. So, in normal people usually don't react to that, and the tonic people they contract to the smallest, the diluted dose of pilocarpine. That is a pharmacological testing. Some peoples in third nerve also respond to 0.1% pilocarpine. So pharmacological testing alone should not be the criteria. So sometimes if there is a reaction on the normal side also, we should not think it is a tonic people. So usually, so you have to take all the findings together. The patient having this classical not reacting to light and near contraction and the pilocarpine test and the sector palsy, everything together gives a clue that it is a Holmes Adie people. So you have to take all the findings together. So what's the treatment? Most patients do not require any treatment. The treatment for the impairment of the eyes that is due to accommodative paralysis is to prescribe reading glasses. They are difficult in reading, you prescribe a reading glass for them. Otherwise, if they are managing, no need to trouble them. Topical low-dose pilocarpine or physostigmine drops may be administered as a treatment as well as a diagnostic measure. That all depends upon whether the patient is symptomatic and it is producing a lot of problems to the patient. Prognosis, it needs reassurance. Rare associations of angle closure glaucoma with the tonic people. So patient developing eye pain, periorbital pain, unilateral headache, and with the tonic people, keep in mind you have to measure the ocular pressure because there is a rare association of angle closure glaucoma with the tonic people. Accommodative paralysis gets better spontaneously over time. The pupil light reaction becomes weaker over time with an increasing light near dissociation, and the pupil becomes smaller with time, which is called as little old Adie. As I was telling, not reacting much to light, and near contraction is there, and over a period of time, the tonic pupil, which is larger than the normal size people, becomes smaller over a period of time. That is called as little old Adie. So you should not be surprised the tonic people is smaller than the normal size people. It can happen over a period of longer time follow-up. That is called as little old Adie. So this is my last slide. You can see this is drawn by me in the hand. So the tonic people, the right side is a tonic people and the left side is a normal people. And it in lower light, both peoples are dilated. If there is not much light there, the both peoples are dilated in the normal the low light kind of situation. The picture below that, the first thing, and it is written by my hand, bright light, right tonic people poorly constrict. So if you throw a strong light or a torch light to the right eye, it poorly constrict. That gives a clue that it is a tonic people. The left eye is constricting well to the light. And there's on the right side of the slide, the blue colored one, the near response is present. So you can see the right eye and the left eye. So the eyes are converging and there is a contraction of the pupil to near response, but it can be still, it is larger than the normal eye, but it constricts comfortably and relaxes slowly after that. The fourth picture, the bottom of the blue picture, is 0.1% pilocarpine to the right side. That is a tonic pupil. and there is a constrictor response. The left eye is the normal people that usually because very diluted pilocarpine, it doesn't react to that. The right people, the tonic people is constricting to the low dose pilocarpine on the right side, and the left side there is not much response because it's the normal eye. So these are the Holmes Adie people or tonic people looks like. So today my topic, I just want to focus only into Holmes. In conclusion, tonic people, Holmes Adie people, or Holmes Adie syndrome, it all depends upon the additional findings. So the patient can have a tonic people one side or both 80% one side in 20% bilateral, and over a period of time the tonic people become smaller. That is called as little old ID. And I told you what are the pharmacological tests and how to diagnose clinically. And they can have additional features like absent reflexes. They can have dysautonomia, and there can be secondary causes of Holmes Adie syndrome. So the secondary infection, secondary to autoimmune disorder, secondary to trauma, secondary to the vasculitis and all those problems. So when a patient has some systemic problems and you find this finding, you have to keep in mind whether it is a primary idiopathic tonic people or whether it is secondary tonic people. Thank you very much for listening to me.
Wonderful talk, Pazhani. Enjoyed it.
Thank you, madam.
Nice. I like the little old Adie. New information.
Little old Adie, yes.